these are the uncovered sections, and please, you have to go through it by yourself. This doesn't mean that it's not important. And there are things that will be covered by my colleagues: muscle mash, hyperlipidemia, and hypertension. It will be given during the course. So I'll begin with the story of Mr. Fahad. He is a 30-year-old gentleman, previously healthy. He was hanging out at Avenues Mall. He was having his coffee, where he was approached by an enthusiastic family medicine resident, Dr. Zainab and Amal, and her friends. They were arranging a campaign about diabetes screening. So, by the way, this is Carlos Sainz from F1. Do not upload the presentation in the media عشان ما يقاضيني. But let's see the story of Mr. Fahad. So during this campaign, they used two tools in order to screen for diabetes type 2: informal assessment of risk factors and validated risk calculator. And whoever tested negative, they were telling them to recheck after 3 years or according to risk factors. So this is diabetes risk test, which is the validated test. So whoever tested or scored 5 or higher, they were offered him random blood sugar by glucometer, or they were just asking about the risk factors. So what are the risk factors, or who should be screened for diabetes? So testing should be considered in adults with overweight or obesity, BMI more than 25, or 23 in Asian, who have one or more of the following risk factors: first-degree relative, high-risk race or ethnicity, history of cardiovascular disease. If they are hypertensive and their blood pressure is more than 130/80, before 2 years it was 140/90. Now it's changed since the last update. If the HDL cholesterol less than 0.9 millimole per liter or triglyceride more than 2.8, individuals with polycystic ovary syndrome, physical inactivity, or if they have signs of insulin resistance like acanthosis nigricans, people with prediabetes, more than HbA1c more than 5.7, people who were diagnosed with gestational diabetes also should be screened at least every 1 to 3 years. All people should be screened once they reached 35. Before it was 45. If results are normal, testing should be repeated at a minimum of 3 years interval. There are some people also with a high risk, people with HIV, or if they had like pancreatitis or on a specific medication, also we should screen them for diabetes. There are specific group I want you to check. They should be screened by a specific test, not the usual test. For people with hemoglobinopathies, G6PD, people who had like recent blood loss, hemolysis, anemia, people with HIV or pregnant ladies, we shouldn't use A1C. We should use fasting plasma glucose for screening. For people with HIV, screening should be before 3 to 6 months after starting them on the antiretroviral, and it should be screened by fasting plasma glucose. People with acute pancreatitis also, we should screen them 3 to 6 months after getting the pancreatitis, and then annually. And we can use any of the tests. For cystic fibrosis, annual screening should begin by the age of 10 by OGTT. Post-transplantation, OGTT is advised. Patients suspected to have monogenic diabetes we can use any of the tests. And patients on statin, thiazide, glucocorticoids, HIV medication, antipsychotic, we can use any of the standard tests. So back to Mr. Fahad. So when they give him the diabetes diagnostic test, the screening test, he was scoring more than 5, so they offered him random blood sugar. Unfortunately, it was 14.7 millimole per liter. So Dr. Zainab and her friend referred Mr. Fahad to his primary care. So for the diagnosis and classification, we have 4 diagnostic tests: A1C, fasting plasma glucose, OGTT, 2-hour plasma glucose, and the random plasma glucose, and it should be with a classic hyperglycemia symptoms. So for the A1C, anyone having the blood sugar from 5.7 to 6.4, the patient is considered as pre-diabetic. And if the HbA1c is more than 6.5, he is diabetic. For the fasting, if the fasting blood sugar from 5.6 to 6.9, the patient is considered as having pre-diabetes. And if it was more than 7, he is diabetic. So for the OGTT, if post 75 glucose solution, if they had the reading from 7.8 to 11, he is pre-diabetic, or the patient is pre-diabetic. If more than 11.1, the patient considered as diabetic. For the random blood sugar above 11.1, the patient is considered diabetic and he should be symptomatic. So we usually use fasting plasma sugar and A1C as a routine screening tool, but the OGTT diagnoses more diabetes than the other 2 tests. And now CGM is trending, but there is insufficient evidence to support the use of CGM for screening or diagnosis of pre-diabetes or diabetes. And you all know that A1C is useful to determine chronicity of hyperglycemia. So, in the absence of classic hyperglycemic symptoms, we should repeat the testing, regardless of the test used. We should confirm the diagnosis by repeating the test. This can be accomplished by 2 abnormal screening test results measured either at the same time or at 2 different time points. Okay, if we have 2 tests, 2 different tests, and both are above the normal range, so this patient is diabetic. What if we have discordant results? We should repeat the test with the higher reading. But if the test was HbA1c, just make sure that there is nothing falsely elevate or reduce the HbA1c. So if we repeat the higher test and it was positive, so the patient is considered as having diabetes. And consider when you are using the OGTT, the carbohydrate intake, the patient should consume at least 150 grams per day before 3 days before the testing. Otherwise, we will have false positive OGTT. So back to Mr. Fahad. So he went to his polyclinic, fasting blood sugar was done. It was 8.9 and HbA1c was 8.8%. So we have 2 high readings. So this confirmed that Mr. Fahad is having diabetes. He was started on glucophage XR 1000 milligram, 2 tablets once daily, along with lifestyle advices and dietary counseling. After 4 weeks of adherence, the test was repeated and it was still elevated. His reading was ranging from 9.2 to 10.1. So the doctor started him on Januvia 100 milligram. But after 4 weeks, Fahad began to develop mild weight loss and fatigue. His fasting is still uncontrolled. it was 9.5. So what do you think? So we might think that this his diagnosis was wrong at the first place. So in ADA 2025, they were focusing on screening not only for type 2, but also for type 1 diabetes. How we should screen patients if we are suspecting that they are having type 1 diabetes through autoantibodies, the JAD, islets antigen 2, and zinc transporter 8. So who should we screen for type 1? Patients with a strong family history of type 1 diabetes or otherwise known elevated genetic risk. If the patient tested positive and he's still asymptomatic, we should repeat the test after 6 months, and we should do OGTT annually, and we can modify the frequency according to individual risk. So why it is important to know the stage? We have for type 1, 3 stages: stage 1, stage 2, and stage 3. And at stage 1, the patient will test positive for the autoantibody, but we will not have any symptoms. At stage 2, the patient will test positive for the autoantibody, but his sugar will be like pre-diabetic range. At this stage, we can introduce, or there is a new drug, which is monoclonal antibody, teplizumab infusion. We can introduce it here if the patient is over the, or if the patient age was more than 8 years. And we can delay the onset of stage 3 or type 1, symptomatic type 1 diabetes. So at stage 3, the patient will have positive antibody, will have hyperglycemia, and the patient will be symptomatic. هذا خبر كان بالقبس, بس I'm not sure if we are having this monoclonal antibody in Kuwait. So this is the classification of diabetes. We have type 1, type 2, gestational diabetes, and diabetes from other causes, which is monogenic diabetes, and diabetes from pancreatitis or drug-induced. So why it is important to know the classification? Because the management will differ. Before, we used to say that type 1 diabetes is only for young and type 2 is for adult, but this is not anymore. This is not accurate, as both diseases occur in all age groups. So if you suspect a patient with type 1 diabetes, go through this diagram. I will not go through it, but it's all about autoantibody and C-peptide. This is a nice table to differentiate between type 1, type 2, LADA, and monogenic or moody. So this is there is one useful clinical tool for distinguishing diabetes types, which is AABBCC. The A is for autoimmunity and age. So type 1 and LADA are autoimmune. The other A is for age. So if the patient was less than 30 years of age, we will suspect that he is having type 1. If it is more than 40, type 2, between 30 to 50, LADA, and less than 25, we will think about genetic. So the B is for background, family medicine, family history. So in monogenic diabetes, the family history will be strong. Or body weight, the other B is for body weight. In type 1 and LADA, the patient might be lean. Type 2, overweight. Moody, the BMI will be normal. And DC is for C-peptide. For type 1, it will be low. Type 2, normal or high. LADA, at the beginning, it will be normal, then it will be low, and the patient will be symptomatic. And in monogenic diabetes, it's normal. And in type 1, the patient, so the other C is for complication. The patient will have ketoacidosis, and also a patient with LADA might have moderate risk of getting ketoacidosis. So back to Mr. Fahad, further evaluation was done to rule out other types of diabetes. Investigation revealed that the patient is, or Fahad is having low C-peptide. JAD was, antibodies were positive, so the patient was diagnosed with LADA. So his doctor stopped all oral medications and started him on insulin, and he was referred to secondary care. So now we will move to comprehensive medical evaluation and assessment of comorbidities. So we should always be patient-centered. In order to prevent complications and optimize the quality of life, we should assess the patients for their priority, for their comorbidities, for their compliance, control, complications. We should assess their mental well-being, their caregiver mental well-being. We should consider specific factors that impact the choice of treatment, like multiple hypoglycemia attacks, having like cardiovascular disease, chronic kidney disease. If the patient is elderly, and we should consider the cost, the availability of the medicine. Some medicine are frequently not available, unfortunately. So all of these we should consider. And if we put a management plan, it should be shared with the patient, and the patient should agree on it. The management plan should be smart. We will monitor the plan later with physical activity and lab investigation, and we will review every time. So if you are exposed to the diabetes clinic, you will know this will be familiar. And if you are seeing frequently at the general clinic, you all should know what history to take. So there are something to cover at initial visit, something to cover every follow-up visit, and something that we should do annually. For every follow-up visits, always cover hypoglycemia. If you missed hypoglycemia and if you don't discuss it in every visit, this is a safety issue. You have to ask about hypoglycemia. You should know if the patient knows how to deal with hypoglycemia. They added recently in 2025 disability assessment. We should assess disability at every visit. Okay. Also the diet, exercise, and they added sleep behavior. Also sleep, we should ask the patient about their sleep patterns and at every visit. Okay. And if the patient is on CGM, please do not forget to check for the CGM results. And we will talk about it later in details. Okay. And for things that should be covered annually, we have the vaccination, comprehensive food exam, because food exam, we should do the inspection at every visit. Comprehensive food exam, including the ankle brachial index, it should be done annually. Fundus annually, and I will talk in my second lecture about fundoscopy. And if there is any problem, we can do it more frequently. And also the urine microalbumin and ACR should be done annually, unless if we have a problem. They added something new, the bone health as well. So we should assess the patient bone. So if the patient did not do the osteoporosis screening, we should offer them a bone scan. What physical examination we should do at every follow-up visit? The BMI and the blood pressure, the inspection skin examination, and as I said, we should check the foot as well, inspection. So these are the vaccination that we should offer for the patient as anticipatory care. They added shingles, zoster, any adults above 50 years, any adults 50 years or older should be offered shingles or zoster. Before it was only available in the hospitals. Now it's available in some of primary care. احنا بالكابيتال عندنا بالصقر. It's available بالعديلية. So for the screening updates, as I said, disability should be screened at initial visit and every visit, and functional decline. For the peripheral vascular disease, peripheral arterial disease, we should do the ankle brachial index for patient at risk of it, or any patient with diabetes more than 10 years duration and they have high cardiovascular risk. For the male, please don't forget to screen for erectile dysfunction. This is from the previous updates, but they added we should monitor serum testosterone if there's a patient symptomatic of hypogonadism in men. So if they are complaining of decreased libido, infertility, if they are having testicular atrophy, we should do serum testosterone. For women, we should also screen for problem in the sexual health and symptoms of genitourinary syndrome of menopause. We should screen not only patient, also the caregiver for concerns, including diabetes, distress, depression, anxiety, fear of hypoglycemia, and disordered eating behavior. And in 2025, they add for the screening, risk assessment before fasting in Ramadan. And you can find it in their guideline. What other things we should screen for in patient with diabetes? We should screen for something called MASLD, metabolic dysfunction associated steatotic liver disease. 70% of patients with type 2 diabetes will have MASLD. Why we should screen for MASLD? Because the patient is at risk of cirrhosis and hepatocellular carcinoma and death. Who should we screen for MASLD? People with central obesity and cardiometabolic risks or insulin resistance, individuals more than 50 years of age, those with persistent plasma aminotransferase more than 30 units, and if it was more than 6 months. What tool we should use for MASLD? We should use FIB4, FIB4 based on person age, ALT, AST, and platelet count. And you can use the calculator from medcalc.com. So if the patient scored more than or equal 1.3, we will offer fibroscan. We will refer the patient for fibroscan, where the liver stiffness measurement will be measured. And if it was more than 8, the patient will be followed by hepatologist. If it was less than 1.3, we will manage at primary care. We will manage the risk factors and we will give advices regarding lifestyle modification. If the liver stiffness, if the FIB4 was more than 1.3 and the liver stiffness less than 8, also the patient will be followed by primary care. What I want you to know that FIB4 has not been validated in pediatrics or in adult less than 35. And the cutoff is different in elderly. If the patient is more than 65, the cutoff 1.9 to 2. So I'm not going to go on in details for muscled and MASH, but what we used for muscled, if we want to treat a patient who's having muscled, it's better to offer GLP receptor agonist or dual GIP-GLP receptor agonist, which is the Monjaro. And if the patient is having MASH, we can use GLP receptor agonist with pioglitazone. So as I said, bone health is very important because both type 1 and type 2 are prone to complications. So they are prone to falls, they are at risk of falls, they are having macrovascular complications, they might have hypoglycemia, elderly might have sarcopenia, they might have poor vision, neuropathy. So we should assess their bone health. We should ensure that they are having adequate calcium intake, and we should check for their vitamin D level. And if they didn't do bone scan, we should offer a bone scan. We should screen for osteoporosis. Always give advices about fall precautions and advices about physical activity, aerobic and weight-bearing physical activity. For the vascular disease, patient with prediabetes at risk of cardiovascular risk. So it's very important to screen for prediabetes and to manage the modifiable risk factors to prevent the cardiovascular disease. Statin therapy may increase risk of type 2 diabetes, so any patient on statin should be screened for diabetes, but please do not stop statin if you have hyperglycemia and you suspect that the statin is the cause of hyperglycemia. You should always outweigh the risk and benefit. In people with a history of stroke and evidence of insulin resistance and prediabetes, pioglitazone, which is Actose, it's not available in the government, but I think it's available in private, may be considered to lower the risk of stroke or myocardial infarction. However, again, we have to measure the risk and benefit as the pioglitazone increase the risk of weight gain, edema, and fractures. So now, if we have a patient with prediabetes, we want to delay or prevent developing diabetes. So always facilitate weight management in those patients who are overweight or obese and they are having prediabetes to minimize the progression to hyperglycemia and to reduce the cardiovascular risk. Who should we, we should treat intensively? A patient with BMI more than 35, patient with fasting glucose from 6.1 to 6.9 and 2 hours post-challenge from 9.6 to 11, and who are having persistently HbA1c above or equals 6, and patient with gestational diabetes. So in patient with prediabetes, we will provide for them advices just like type 2 diabetes. So encourage them to achieve and maintain a weight reduction of at least 7% of initial body weight, and to have physical activity more than 150 minutes per week of moderate intensity physical activity, like brisk walking, and to break up the prolonged sedentary time. Advise them to have Mediterranean diet, DASH diet, intermittent fasting, and low carbohydrate diet. They add in 2025 sleep. Also give advices about sleep and sleep hygiene. Always ensure they are having adequate sleeping time, and ensure that the quality is good and the quantity as well. The sleep should be not more than 8 hours, not less than 6 hours. This is negatively will impact the HbA1c. So beside physical activity and diet, also you should provide advices about sleep hygiene. So in patient with pre-diabetes, how we will manage beside the lifestyle modification and advices, some patient we might offer metformin. Who are the patient that we should consider metformin therapy for? Adults aged from 25 to 59 years with the BMI more than 35 or equal 35, individual with higher fasting plasma glucose more than 6, or those with higher A1C more than or equal to 6%, individuals with a history of gestational diabetes mellitus. So please do not hesitate to start metformin. Do not delay the start of metformin. So if you start metformin, you should check for vitamin B12 periodically, especially if the patient was complaining of numbness and signs and symptoms of peripheral neuropathy or having anemia. The dose for pre-diabetes, 1,500 milligram. So Mr. Fahad was happy with the primary care management, so he brought his father. حتى هذا أبو كارلوس ساينز from أخوان. So بس هو الحين اسمه Mr. Jassim. So Mr. Jassim, 66 years old, known case of diabetes, hypertension, and dyslipidemia. So he is on metformin, XR 1000 milligram PD, Trajenta. I want you to capture just this because we will go back to it. I want you to see his medication and to put a plan. Always, if you are in a general clinic and you are in a doubt, put your plan, then ask your senior. Don't refer the patient without a plan. Try your best and they will correct you. They will help you. The seniors, of course, they will help you. So this patient was on metformin, Trajenta, Lantus 40 units, Dimicron 60 milligram OD, Exforge 10 milligram, 160 milligram, Lipitor 40. Last follow-up at diabetes clinic last year. So he was just having a repeated prescription. He was unhappy with the other doctors, so he just take his medication and he goes home. So you requested for him RFT, LFT, lipid profile, urine microalbumin, ACR, HbA1c, and vitamin D. He told you that he's having a frequent hypoglycemia attacks, but today's fasting blood sugar was 12 and his BMI is 27. So you decided to offer him CGM. So now I'm going to talk about glycemic goals and target. So how we will assess the glycemic status? Through two things, either through A1C or CGM. So if we are using A1C, how frequent we should check for the A1C? And those meeting treatment goals, at least 2 times. And those with complications like hyperglycemia, hypoglycemia, at least 4 times a year. So you should individualize A1C goal according to the patient. So if we are having healthy patient, a newly diagnosed, the duration of his diabetes is short, he's healthy with low risk of hypoglycemia, no comorbidities, the HbA1c target should be less than 6.5. And شوية, most adults and healthy from 7.5, less than 7.5 to 7. In older adults with complex health, less than 8%, but an older adult with poor health, short life expectancy, we do not recommend you to do HbA1c. So this is the CGM and how to read or interpret the CGM. You should check or if you are reading the CGM, do not see only for 1 week. the patient should wear it more than 14 days, and the active time should be at least 70%. Okay. What is important is here the coefficient variation. It should be less than 36%. And we have time above range, time in range, and time below range. So time above range, if it is more than 13.9, it should be less than 5% in most adults. For older adults, it's advised to be less than 10%. Time above range from 10.1 to 13.9, in most adults, it should be less than 25%. In older adult, less than 50%. Time in range, and this is our target, from 3.9 to 10 should be more than 70% in most adults, and in older adults, more than 50%. Time below range, from 3 to 3.8, it should be less than 4 in most adults, but elderly, less than 1%. And of course, time below range, below 3, it should be less than 1 in both. We don't want to see less than 3 in elderly. So this is what you will see بالCGM. So you will check the time in range, time above range, time below range. So we will see the glucose variability. It should be less than 36. And some of the CGMs do not include variability, so you will see the picture, the graphs, if it is above or below. Excuse me. So for the CGM, now in the new update, they recommend offering all the patients with diabetes at diagnosis, regardless of types, type 1 or type 2. Okay, but this is impossible. First, the CGM will give us a clue how to manage the patient, but it is impossible to offer all the patient CGM because it's costly. So higher recommendation for person on multiple daily injections or pumps or medication that can cause hypoglycemia. And it is recommended for older adults to reduce the risk of hypoglycemia, noting A1C may be less reliable in this population. By the way, if we want to compare between CGM and A1C, CGM will show us variability, whereas A1C will not. So, for example, we might have 2 patients with A1C of 8%, but some patient most of the time is having the blood sugar 8, but no hypo or hyper, and other patient with the same HbA1c, but he might have hypoglycemia and hyperglycemia, but the HbA1c is 8%. So CGM is better to check for variability. And variability, the more variability, the more risk of cardiovascular disease. CGM is also now supported for all pregnant individuals with diabetes, not only type 1, because it will provide better glucose control and outcome. We talked about the elderly and their targets, but what I want you to know that we should de-intensify or simplify the plan if the elderly is having severe and recurrent hypoglycemia, if their health is deteriorating, or if they are in the hospital or they are having acute illness. And I will tell you later how to do this. So this is Mr. Jassim CGM. So as you can see, the time above range was 44. It should be less than 25. Time in range was 46, and we said the target should be more than 70, and his time below range, it was 10%, and we wanted less than 4. So we should, and the variability was more than 36. So we should deal with this issue in order to reduce the cardiovascular risk and hypoglycemia. Okay. So in the update 2025, they focused on the obesity and weight management. So how we manage obesity? A holistic approach to weight management is essential. Individualized strategies may include nutrition, exercise intervention, behavioral counseling, pharmacotherapy, and metabolic surgery. So in people with diabetes type 2 and overweight or obese, or they are obese, weight management should represent primary goal of treatment in this group. Weight management is important because we will delay the progression. If the patient was pre-diabetic, we will delay the progression into type 2. It's highly beneficial in treating type 2 diabetes. It will improve the HbA1c. It will improve, it will reduce the need for other glucose-lowering medications. It will reduce the risk of cardiovascular. It will lower long-term cardiovascular and mortality risks. And of course, it will reduce obesity complications. So if you are dealing with a patient with who is overweight or obese, avoid person with obesity, avoid obese person, use person with obesity. Do not say diabetic person. We should say person with diabetes. So always be patient-centered, non-judgmental, and use proper language. So we should, before introducing pharmacotherapy, we should measure BMI. Not only the pharmacotherapy, also behavioral counseling, we should check BMI. We should measure waist circumference, waist to hip ratio. And we monitor this parameter at least annually. So in patient, if the BMI from 25 to 26.9, we will offer behavioral counseling. From 27 to 29.9, we might offer, or we should offer, weight management pharmacotherapy. If it is more than 30, we can offer metabolic surgery. So for weight loss efficacy glucose-lowering medications, we have the Mounjaro. Mounjaro is the most effective now. It's more effective than Ozempic. Ozempic and Wegovy are more effective than Victoza and Saxenda. Victoza and Saxenda are more effective than Trulicity, and Trulicity more than Bydureon. So we have a new agent, but it is now, it's under observation, still not introduced yet, which is retatrutide. It's GLP receptor agonist, GIP, and glucagon hormone receptor agonist. Here is what is available. We only Trulicity and the Victoza and available in the primary care. But I think in hospitals, Ozempic is available, and the oral repulses. So what I want you to consider before adding this medication, you should review if the patient has personal or family history of medullary thyroid carcinoma, and if the patient is having history of pancreatitis. Always do a baseline labs which includes LFT, EGFR, lipid, consider amylase and lipase of pancreatitis risk. Always start with low dose and titrate slowly. اللي عندنا الوحيد اللي ما نسوي له titration the Trulicity. Titration is important to reduce GI side effects, which is nausea, vomiting, diarrhea, constipation, abdominal pain. Always encourage patient to drink plenty of fluids. encourage hydration. So, after achieving weight loss goals, continue monitoring and support to maintain weight loss. And please do not stop the pharmacotherapy suddenly. Sudden discontinuation of weight management of pharmacotherapy results in weight gain and worsening of cardiometabolic risk factors. Screen them for malnutrition because, they are prone to have a vitamin B12 deficiency, they might have iron deficiency, vitamin D deficiency. So you should screen for malnutrition. If the patient was offered metabolic surgery, offer CGM. It's very important to improve safety from hypoglycemia risks. In people who undergo metabolic surgery, routinely screen them for psychosocial and behavioral health changes and refer them to behavioral health professional as needed. So now we will move on to the most important part, which is pharmacologic approach to glycemic treatment. So please avoid therapeutic inertia. Always, if you see that this patient is intensifying the treatment is important, please do not delay intensifying the treatment. Always be person-centered. If you are person or patient-centered, the patient will adhere more, or the patient will be more compliant to his medications. Use medications that provide sufficient effectiveness to achieve and maintain intended treatment goals with consideration of effects on cardiovascular, kidney, weight, and other relevant comorbidities like muscle and MASH, and hypoglycemia risk, cost and access, and risk of adverse reaction and tolerability, and of course, individual preference. We can use combination therapy from the beginning if it is required to shorten time and to reach the glycemic goal. So, Mr. Jassim came to you with his labs. Just capture his lab and keep it and think about his treatment plan. So he came with urine microalbumin 35, ACR 400. His EGFR was 28, and his cholesterol was 5.52, LDL 2.8. So think about management plan. We will go back to Mr. Jassim after a few slides. So this diagram, or I will go into details about each part. So in adults with type 2 diabetes and established or high risk of atherosclerotic cardiovascular disease, the preferred medication is either GLP receptor agonist with a proven cardiovascular benefit, or SGLT2 with a proven cardiovascular benefit. If the patient was on GLP receptor agonist and is having he's having risk, cardiovascular risk, or indicators of high cardiovascular disease risk, and the A1C is still not achieved, you can add SGLT2 and vice versa. If the patient is having cardiovascular disease and the HbA1c is fine and he was diabetic, we will start him on GLP or SGLT2 irrespective of A1C, because we want the benefit of the cardiovascular benefit. So in case of heart failure in adults with type 2 diabetes who have heart failure with either reduced or preserved ejection fraction, an SGLT2 inhibitor is recommended for both the glycemic management and prevention of heart failure hospitalization, again, irrespective of A1C. Okay, what if the patient has heart failure, preserved ejection fraction, but obese? GLP receptor agonist is preferred. And then in the diagram, it's still not there, this information, but in the update, the 2025, it's there. So just consider this. If the patient is having heart failure, type 2 diabetes, and obese, GLP receptor agonist is preferred over the SGLT2. Again, irrespective of A1C. So if you noticed, I've highlighted the updates in red. For the chronic kidney disease, in adults with type 2 diabetes who have chronic kidney disease with confirmed estimated eGFR from 20 to 60 or albuminuria, and this should be repeated. The ACR or albumin, we should make sure that this is repeated. An SGLT2 receptor, SGLT2 inhibitor or GLP receptor agonist is preferred, irrespective of A1C, because these will slow the progression of chronic kidney disease and reduce cardiovascular event. The glycemic benefit of SGLT2 after, if the GFR is less than 45, will be reduced. However, we will still continue the SGLT2 inhibitor because we wanted to prevent chronic kidney disease progression. So we will continue taking or giving the SGLT2 inhibitor if the eGFR is less than 45 because of we want to delay or prevent chronic kidney disease progression. In adults with type 2 diabetes and advanced chronic kidney disease, if the eGFR is less than 30, GLP receptor agonist is preferred for glycemic management due to lower risk of hypoglycemia and for cardiovascular event reduction. So SGLT2 can be started with eGFR more than 20, but if it is less than 20, we will use GLP receptor agonist. Okay. So what I want you to know, if you started the patient on SGLT2 inhibitor, always monitor RFT. After starting or initiating SGLT2 inhibitor, we will expect that the patient will have mild reduction in eGFR. This is okay. It will stabilize later. Always ask about genitourinary infection if the patient is having dysuria. Ask about side effects in every visit. And you should educate the patient to report DKA symptoms, which include nausea, abdominal pain. The patient might be also breathless, even if the sugar was normal. They might have ketosis and the blood sugar is normal. So again, ask or encourage hydration and temporarily hold the SGLT2 inhibitor in case of acute illness or major surgery. And now it's available for non-Kuwaiti as well. So we've talked about muscle and MASH and what is the preferred agents. So where does metformin fit? We talked about SGLT2 and, inhibitor and GLP receptor agonist too much. Where does metformin fit? So we can use metformin as add-on to any of the drugs used for comorbidities, اللي كانوا for cardiovascular disease or the chronic kidney disease, GLP receptor and SGLT2. We can add the metformin as add-on or as a starting agent for a person without any of the comorbidities. Metformin is commonly used medication as first line before, but not anymore. Metformin is effective and safe, inexpensive, and widely available. We have it in two forms, the XR and the immediate release. The extended release, the XR given once daily, immediate release twice daily. Maximum dose 2000 milligram. Metformin may be safely used in people with estimated GFR above 30. If the eGFR below 30, please stop it because of risk of lactic acidosis. What are the side effects of metformin? GI intolerance, and we can overcome it by using XR or by titration. And again, we have said that metformin is associated with increased risk of vitamin B12 deficiency and worsening of symptoms of neuropathy. So we should periodically measure vitamin B12. So when to use injectable therapy. If the patient wasn't on injectable therapy, what to consider and when to consider it. So, which therapy should I start first? If the patient wasn't on any of the injectable therapy, GLP receptor agonist or GIP-GLP, اللي هو المونجارو, is preferred before insulin. When should I start insulin first? If there are symptoms of hyperglycemia like polyuria, polydipsia, or there is evidence of catabolism, unexpected weight loss, or if when the A1C is above 10% or the blood glucose above 16.7 equals or above 16.7. Can we use a combination اللي هو ال GLP مع الانسولين? Yes, we can. And if we add the GLP and the patient was on insulin, we should de-intensify and adjust the doses. So I can't, okay. So as I said, if the patient is not on injectable therapy, GLP receptor or the dual GLP receptor agonist is preferred over the insulin. If the patient already on GLP receptor agonist or a dual GLP receptor agonist, and we want to intensify the HbA1c not on target or above the goal, we will add basal insulin. How? Either by giving the patient 10 units or by calculating it through according to weight. And to be honest, I prefer calculating it according to weight, 0.1 to 0.2 units per kg per day, because some patients are overweight or obese, so 10 units will not be enough. We will follow fasting plasma glucose every 3 days, and we will increase by 2 units every 3 days if the fasting plasma sugar not reached yet the goal. And if there is hypoglycemia, we will reduce the dose by 10 to 20%. If the patient if we reached the maximum basal insulin and the patient still uncontrolled, and we want to add the boluses, we will choose the largest meal. We will use 1 dose. We will start with 4 units, and we will increase the dose by 1 to 2 units twice weekly. So, for insulin therapy, long-acting basal analog, which is 100 glargine, اللي هو Lantus, is preferred over the MPH because the risk of hypoglycemia is less in Lantus than MPH, but the longer-acting basal analog, اللي هو 300 glargine or Diclodec, Litresiba and Toujeo, convey a lower nocturnal hypoglycemia risk than Lantus. فإذا عندكم patient still على Lantus and they are complaining of hypoglycemia, please switch between the insulin. Use Toujeo or Tresiba instead.
Dr. Taibah?
Yeah.
You have 10 minutes left, please.
Okay. So for insulin updates, as I said, GLP receptor agonist, GLP and GIP preferred. And you know when to use insulin from the first time. We've talked about this. If insulin is used, combine it with GLP or GLP, GIP. Why? Because it will provide better effectiveness, and we will lower the risk of hypoglycemia, and we will need lower insulin dose. Okay, if we want to switch between basal insulin, we will use unit by unit. يعني إذا كان على مثلا 20 lantus, we will give the patient 20 Toujeo, for example. But if the patient is at risk of hypos, we will reduce the dose by 10 to 20%. All the individuals, if we start them on insulin, we should offer them glucagon. Okay. Before, over-basalization was based on the weight, not anymore. Now it's not about more than 0.5. This is removed in the new update. Instead, assess over-basalization by bedtime reading and morning time, and pre to post prandial difference. If it is more than 2.8, the difference between two readings more than 2.8 means we have over-basalization, or basically if the patient is complaining of multiple hypoglycemia attack, or if the patient is using CGM and there is high glycemic variability. So this means that the patient is having over-basalization. Reminder, when initiating insulin, continue metformin, SGLT2 inhibitor and GLP receptor, and stop sulfonylurea, meglitinides, and DPP4, because they have no additional beneficial effects on cardiovascular, kidney, weight, liver, and these classes increase the risk of hypoglycemia and weight gain. So for the simplification of complex insulin therapy in elderly, as we said, if they are having multiple hypoglycemia, if they are sick, if their health is deteriorating, please change time of basal insulin from bedtime to morning. This will reduce their nocturnal hypoglycemia. You will have better titration and monitoring. This will enhance fasting glucose interpretation. It will support insulin de-intensification and fits better into daily routine. How we will do this, we will see our goal is from 5 to 8.3. We will check fasting plasma sugar over 1 week. If the patient is having more than 50% above the goal, for example, for readings above 8.3, we will increase by 2 units. And if more than 50%, less than 4.4 millimole, we will decrease by 2 units. This is how we will adjust the dose of basal and elderly. So prandial, if the prandial was more than 10 units, reduce dose by 50%, and add non-insulin agents if they are not in any, اللي هو GLP receptor agonist to SGLT2 inhibitor and metformin, but check the eGFR first. Gradually taper down prandial insulin until you discontinue prandial insulin if glycemia is controlled. If they are only, if the prandial insulin less than 10%, the 10 units, sorry, you can discontinue prandial insulin and add non-insulin agents if they are not on any. For example, you can read it by yourself, how we will reduce and stop. So back to Mr. Fahad. I want you in the chat to tell me what you will do. Will you offer SGLT2 for Mr. Fahad or GLP receptor agonist, and what you will do for other medications? Okay, stop metformin. بعد شنو بتسوون؟ GLP. GLP. Stop metformin and add GLP. Only metformin, you will stop only metformin. He's not on SGLT2. He's only on metformin, Lantus, dimicron, Exforge, Lipitor. So you will stop dimicron. He's not on DB. Okay, we will stop DPP4. Yes, you are right. So we will stop metformin, we will stop Trajenta, we will add GLP receptor agonist because as you remember, if it is less than 30, GLP receptor agonist is preferred over the SGLT2 inhibitor. And if we add GLP, we will stop DPP4 اللي هو التراجنتا, and he's having frequent sulfonyl. He's having frequent hypoglycemia, so we will stop dimicron. And of course, we will adjust the statin. Okay, for the cardiovascular disease, how many minutes left?
Doctor, it's okay. You can finish the management. We'll give you
Okay.
extra time.
So for the cardiovascular disease and risk management, we don't have actually something to monitor coronary artery disease, to screen for coronary artery disease. If the patient is symptomatic, we will do ECG and the angiogram and whatsoever. For the heart failure, we should screen all adults with diabetes, which increases the risk of for asymptomatic stage B and symptomatic stage C heart failure. How? We will measure it by pro-BNP. And I think they will, يعني it will be available soon بالمراكز الصحية. We can order it. And if we have a high BNP, we will refer them for echocardiogram. For peripheral artery disease, as I said before, we can monitor them through ankle brachial index. If it is less than 0.9, I think, or 0.9, this means they are having or at increased risk of peripheral arterial disease. We will refer them for vascular. Who are at risk? We should screen patient with diabetes more than 65. Diabetic patient with microvascular disease, or they are having food complication, or they are having the diabetes for more than 10 years. All of these should be screened for peripheral arterial disease by ankle brachial index. So diabetes and chronic kidney disease, we should screen them at the time of diagnosis for type 2, after 5 years for type 1, through urinary albumin to creatinine ratio and eGFR. We should do it annually, but again, according to the readings, the frequency might change. It might be more frequent. So as you can see here, non-pregnant people with diabetes and hypertension, إذا عندهم hypertension, A's and ARBs is recommended. For those, as you can see here, اللي عندهم urinary albumin creatinine ratio from 30 to 292, we will start them on treatment. اللي EGFR less than 60, we will start them on treatment. We'll prefer treatment اللي هو A's and ARB, and we should increase the dose to the maximum tolerated dose to prevent the progression of kidney disease and to reduce the cardiovascular event. يعني هنا طبعا مكتوب لكم refer, بس دايما يصير في rejection من nephrologist, unfortunately. If you are lucky, they will accept your referral. Okay. For chronic kidney disease, optimize glucose management to reduce the risk or slow progression of chronic kidney disease. Always optimize the blood pressure. Make sure their blood pressure is below 130/80. Reduce blood pressure variability. It's very important. We don't want too many hypos and too many hyper or high readings. If we started the patient on ACE or ARB, please check for serum creatinine and potassium before starting them, and 1 to 2 weeks after. Check for the level. Monitor for hypokalemia when diuretics are used at routine visit or 7 to 14 days after initiation or after dose adjustment. So if we started ACE or ARB and there is like reduction in, there is increase in serum creatinine, but the increase less than 30%, continue the ACE and ARB. If the patient is not having extracellular fluid volume depletion. And ACE or ARB is not recommended for primary prevention. So إذا ما عنده microalbuminuria ما عنده hyper يعني ما عنده any CKD ما راح نعطيه as a primary prevention إذا ما عنده hypertension وما عنده chronic kidney disease. So to reduce cardiovascular events and chronic kidney disease progression in people with chronic kidney disease and albuminuria ممكن نضيف non-steroidal MRA اللي هو finerenone. That has been shown to be effective in clinical trials. It is recommended if GFR more than 25, but we should monitor the potassium. يعني إذا إحنا عطيناهم AZO ARB وstill they are having microalbuminuria, we can offer them non-steroidal MRA. Our aim is to reduce urinary albumin by more than 30%. Okay. Individuals should be referred for evaluation by nephrologists if they have continuously increasing urinary albumin levels or continuously decreasing in eGFR, or if eGFR is less than 30. Again, if you are lucky, they will accept your referral. For individuals on dialysis, protein intake of 1 to 1.2 gram per kg per day should be considered since protein energy wasting is a major problem للpatient اللي على dialysis. So for neuropathy, you know when to screen for it. Assessment of distal symmetric polyneuropathy should include a careful history and assessment of either temperature or pinprick sensation. For small fibers, we will use temperature and pinprick. For large fiber, vibration sensation using 128 tuning fork. So always make sure that you are using the right tuning fork. All people with diabetes should have annual 10-gram monofilament testing to identify feet at high risk for ulceration and amputation, optimize weight, blood pressure, and serum lipid management to reduce the risk or slow the progression of diabetic neuropathy. And these are the medication with evidence-based. This is the evidence-based management for neuropathic pain. These are the medications that are used for neuropathic pain. Not opioids like tramadol. It's not recommended to use these. We have actually triptazole وتجريتول وسمبالتا بالمراكز الصحية. We can use combination. It might be more effective than monotherapy, بس أنا دايما أخاف من drowsiness. So for the foot care, initial treatment recommendation should include daily foot inspection. البيشنت نفسه لازم كل يوم يشيك على الفوت. Use moisturizer. We don't want a dry foot because the skin will cracks and we will have like ulcer later. Avoidance of self-care of ingrown nails or calyces. لازم يستخدمون well-fitted shoes. ما يسوي pressure. If they are smoking, we should refer them for smoking cessation because this will affect and it might increase the risk of peripheral arterial disease. Perform a comprehensive foot evaluation at least annually to identify risk factors for ulcer amputation. More frequent examination if there is a finding, if there is loss of protective sensation, peripheral arterial disease, or other serious complication. So this is the end. I used the Formula One theme because I know I will be racing with time, my diabetes. Thank you very much. If you have any question, Dr. Zainab can provide my number and I'll be happy to help, and ChatGPT as well. Thank you very much.
Thank you so much, Dr. Taibah, for your lecture. We do have time still, Dr. Taibah. We can give 10 minutes for question and answers if you don't mind. Hello. So, Dr. Taibah, are you going to take the question and answers now? Yeah. Okay. So we'll start with some of the questions. The first question is, thank you for the informative lecture. Is there a score for pancreatitis risk assessment?
What do you mean, core for pancreatic risk assessment?
I am not sure, maybe they mean to say that they're on GLP and stuff and they want to know if they have the risk or not before starting.
If they are, if there is history of pancreatitis, better not to start GLP receptor agonist.
Okay, okay. The second question is, if the patient has low BMI and heart failure, is it still recommended to use GLP?
Yes, we can use GLP receptor agonist, which is, there are some GLP receptor agonist which is less effective than others in weight loss. So we can use GLP receptor agonist if the patient is lean.
Okay. And the third question is, do we provide CGM in primary care? If not, is it indicated to refer to secondary for gestational screen in those refusing OGTT?
So we cannot use CGM for screening, but it's helpful if the patient was diagnosed with diabetes and we want to see the pattern, their diet, if they are having hyperglycemia, hypoglycemia. It will help us to see where is the issue exactly, and it will help us in management. It's available in we can refer the patient to secondary care. Primary care, I think they will provide it maybe soon, but in limited number and not for everyone. So you can, if the patient wasn't on multiple injection, you can offer them if they can afford it. Sure, it's helpful.
Okay. The next question will be, Dr. Taibah, what is the role of GLP-1 in pre-diabetes with obesity?
Weight reduction. It's excellent. I recommend people to use GLP receptor agonist for pre-diabetes. You can use it.
Okay, okay, perfect. And is it superior to metformin?
According to the patient preference, because it will cause weight loss, so it will be more effective.
Okay. Okay, thank you, doctor. And then we have another question. When to change insulin regime from basal only to basal bolus?
When to intensify.
Yes.
Yeah. So that's why we need the CGM. CGM will help us to see if the patient is having hyperglycemia postprandial. If we see that the patient is, after 2 hours of eating, they are having hyperglycemia, we can add the boluses. And if we reach the maximum dose of basal and we are still having hyperglycemia, we will add the boluses with the largest meal. And if it is still uncontrolled, we can add a second bolus.
Okay, perfect. Thank you, Dr. Taibah. I think these were the questions. No more questions here.
So see you.
So I think with this, we will end this session. I would like to thank you again, Dr. Taibah, for this insightful and up-to-date lecture on ADA guidelines. We truly appreciate your time and effort that you have taken to be with us today. Thank you once again for sharing your knowledge. Thank you.
Thank you very much. See you at 2.
See you, inshallah.
Bye.
So now